The first talk is about myths and facts on good and bad cytokines in sepsis. I was thinking about this book that I read 20 years ago, but I still remember it very well, Zen and the Art of Motorcycle Maintenance. I don't know if anybody knows this book. It's not about Zen. It's also not about motorcycle maintenance, but it's written by an author that's very intelligent, but also suffers from schizophrenia. And it's about a motor tour through the United States with his son. And it's a philosophical book about quality and what is good and what is bad. And Phaedrus is actually his alter ego when he was psychotic. And so the quote is, "And what is good, Phaedrus, and what is not good? Need we ask anyone to tell us these things?" Well, apparently for cytokines we do. And so cytokines are proteins that are released by immune cells, and the body uses these proteins that immune cells can talk to each other. They can signal where there is an infection, and also these cytokines are actually programmed to kill bacteria, right? So that's the whole essence of immunity, to recognize and to destroy the unknown, but at the same time to leave alone the self. And of course this might not always completely work, this differentiation to the full 100%. So one of the most famous cytokines, tumor necrosis factor, is actually called tumor necrosis factor because if you add this protein, before people knew what it was, to tumor cells, they die. And so this illustrates that high cytokine concentration can cause collateral damage to the host. And indeed, too much cytokines are associated with bad outcome. So this is a very old study showing that if pro-inflammatory TNF is higher, you're more likely to have shock. If IL-6 is higher, but also the anti-inflammatory IL-10, if it's higher, you're more likely to have shock. And the same for survival. Patients with higher cytokine levels, pro-inflammatory TNF, are more likely to die, but it's also the case for the anti-inflammatory IL-10. And again, this one is showing in patients with pneumonia and sepsis that the ones with the highest levels of cytokines are the ones that are most likely to die. And it's not only the pro-inflammatory cytokines, but also the anti-inflammatory IL-6. So both correlate with mortality. Too much pro-inflammation is not good. Too much pro-inflammation is associated with cytokine storm, shock, DIC, and organ dysfunction directly. However, too much anti-inflammation is not good either. This is related to inefficient clearance of the infection, reactivation of latent viruses that we also know in patients with sepsis, or secondary infections. So if this anti-inflammatory response that is actually aiming to maintain the homeostasis again, if this is too much or too persistent, it's also bad. Well, about the CytoSorb adsorber. So this device consists of billions of little beads, and in these beads there are pores, and based on the size of these pores, they can adsorb molecules, depending mainly on their weight. And just by incidence or not, it's actually the size of the molecules that they can absorb is actually the size of the molecules of cytokines. There's a huge excess area, there's a huge absorption area of all these small little beads. And so once the cytokine gets into that little bead, it's captured. And that's the way actually that this adsorber is clearing cytokines. So to show you some properties of the device in an in vitro setup, the device does not clear endotoxin. It's too big for the pores. In contrast to some other devices like the polymyxin B device that does clear endotoxin, but not the cytokines. But the device does clear all these different kinds of cytokines that you see on the x-axis very effectively. So how would extracorporeal blood purification work? There are a couple of different ideas about that. So one thing is that if we can lower the peak cytokine concentration, that might directly relate to less organ damage and less mortality. So this is the peak cytokine hypothesis. There's also an idea related to the threshold immunomodulation. So if you actually clear cytokines from the circulation, you drain cytokines from the tissues, and therefore there is more of a gradient, and this is favorable to prevent further organ damage. And the last idea is the cytokinetic model, also relating to clearance from the tissues, and that may enhance migration from neutrophils to the infected tissue and therefore better clearance of infection. Now, is the device really able to lower circulating cytokines if there is inflammation in humans in vivo? So a little more than a year ago, we did this study in our institute where we have indeed this endotoxin model where we give a low dose of endotoxin of E. coli bacteria to healthy volunteers, brave young men that also appreciate the financial compensation of this test. And then, so we actually infuse in green endotoxin for a couple of hours. We also gave them a femoral line, and half of the group was put on the CytoSorb adsorber, and the other half was the control group. This is an illustration of how this went. So this is the machine with the CytoSorb. This is the brave volunteer. He's doing well. We will sample a lot of blood, and this is his colleague that is in the control group that is not being tested with the CytoSorb, but does receive the same amount and schedule of endotoxin infusion. And so what we found was a huge effect actually in this very controlled model of sepsis. And as you can see here, TNF, IL-6, IL-8, IL-10, all were significantly reduced in the group that was on the CytoSorb adsorber compared to the control group. Now, we could also sample at the inflow and the outflow of the adsorber, and thereby, using these formulas, calculate clearance and elimination. And so what we found, these are the concentrations that we measured at the inflow and the outflow. We can actually calculate the clearance of all these cytokines you can see here in blue, and also the elimination that is also dependent on the total concentration of the filter. Now, does this translate to patients? Because this is humans in vivo, but it's still a model of systemic inflammation. And I will come to this now and tell you about the issues with the trials that are performed so far. So just by incidence, just a couple of months ago, this meta-analysis was published in Critical Care Medicine. They looked at, so the meta-analysis was actually on, indeed, the effect of CytoSorb on the inflammatory markers in patients. They included 17 trials and over 800 patients. And so let's have a look at actually what was done. So the devil is in the details, because their conclusion is that in patients there is no lower cytokine concentration if you treat these patients with CytoSorb. Well, the thing is that the baseline IL-6 concentrations were only reported in 11 of the 17 studies that were included, and they ranged from below detection limit to about 2,000 picograms per milliliter. So of these 11 studies that actually measured the cytokine, 6 of these studies reported ranges that were within the range of normal volunteers, of a healthy person. So not really elevated cytokine levels. And this is an example of such a study. So this is a study in sepsis patients. It's a randomized controlled trial. And what they find, indeed, is that there's no difference in the group that is treated with CytoSorb and the group that is not. What is of importance is that the level of IL-6 is 500 at baseline. We also measure cytokines for research in our septic shock patients, and we measure about 5,000 or so in septic shock patients. So if the level is lower, this is an issue, and then there's less to clear. So the conclusion is no effect of CytoSorb on circulating cytokines. Well, actually, from the endotoxemia experiment that I showed you, if we actually divide the group in tertiles of high producers and lower producers of IL-6, you can see that the elimination is dependent of how much cytokines are around. So if you have less circulating cytokines, there is less to clear and the whole system is less effective. So this is the idea of concentration-dependent removal. So this is very important for trials. There were also trials done in patients that were under cardiopulmonary bypass because of cardiac surgery. And what they did in those trials, 9 out of the 10 studies, they applied the CytoSorb therapy during the surgery and the cardiopulmonary bypass. At that moment, there are no circulating cytokines yet. We know that circulating cytokines come several hours following surgery. And again, I think it's important first to see that the level of IL-6 and IL-10 is elevated, but much, much lower than in septic shock patients. Again, they find there's no difference, but the issue is the elevation of the level of IL-6, for example here, is at 22 hours to 24 hours, following surgery. And the CytoSorb was actually here. So they're trying to clear something that's not there yet, and then they cannot influence the cytokine response later on. So I think this is also an important limitation of such a study. Then duration of treatment is the third issue. So it was known before that over time the clearance decreases. There's like saturation of the system. And most of these trials, the exchange rate was like once a day. But after 6 hours, the clearance might be really limited. So this is also a relevant issue. And again, we showed that as well in the endotoxemia study, that over time, clearance decreases. And this is a relevant decrease as well. So, is CytoSorb able to lower cytokine in real patients? Well, I'm not saying it works in patients, but I am saying currently we cannot tell whether or not it works in patients because of these shortcomings in these studies. So my conclusions are, good or bad, I think both pro- and anti-inflammatory cytokines can be good, but they can also be bad. Most of the times, too much of a good thing is bad. Too much of a bad thing is worse. And so ex vivo setups, animal studies, the human endotoxemia volunteer study shows that CytoSorb is definitely able to lower cytokine concentrations that are circulating in the bloodstream. The effects of CytoSorb on plasma cytokine concentrations in clinical patients have not been demonstrated, but the reason for this is mainly methodological imperfections in the studies that have been performed so far. So I think that what's really relevant is patient selection. We need to select those patients with the highest cytokine concentrations to be able to clear them. Timing and duration, so you want to treat early, I guess, because the normal course of cytokines in sepsis patients is also decreasing by itself. So you want to treat early, but not too early before the cytokines appeared, like in the cardiac surgery trials. And also adsorber exchange intervals are relevant. There's clearly a drop in clearance after 6 hours. So if you want to be very effective in lowering the cytokines, you might want to actually use more of these adsorbers per day. And these issues are of paramount importance. If we do not take this into account, we will never find a positive signal because of the limitations I mentioned. And with that, I thank you for your kind attention.
Thank you, Peter. It's very clear now. Too much something is not good. Too much love, not good. Too much hate, not good.
I learned this from my wife.
We have to be balanced. Okay, finally, very simple question. Do you think that the cytokines measurements is better than assessing the circulating immune cells' function?
It's a difficult question to answer, I think. I think so. There are multiple things at the same time. Dysfunction of the immune cells is a consequence, likely, of this inflammatory milieu that they are actually swimming in, right? And so if you normalize these surroundings of these immune cells, it's likely that they will also start acting normal again. So this is definitely an issue. At the same time, there is reprogramming of immune cells and things are already changing within the immune cells. So it might be a thing that could also, that you would have to like address the immune cells directly. But I think the whole idea of blood purification, well, it's a nice theory that there is a huge inflammatory response systemically while there's only an infection in the lung. And so everybody, every immune cell is running around crazy and they don't know what to do anymore. And so if you lower it systemically, the focus will be more on the infection itself. And just lower it a bit, you don't have to lower it like to normal, but lowering it a bit might already be beneficial.
Since we are very limited by the timing, so I have a quick question for you. Do you think that the blood sampling for something is a good biopsy to know what happens within the tissues? Simple question too.
I'm already a little less happy that you're back, DJ. You're asking difficult questions. This is also very difficult. So to some extent, it is an illustration of what is happening locally. I think especially at the end of the spectrum. For example, but on the other hand, what we have done, for example, also in the endotoxemia volunteers, we take blood, baseline, normal situation, we stimulate the cells with endotoxin in the lab and measure the next day the cytokine production. And you have high and low responders. And then we give the endotoxin in vivo, and you have also high and low responders. There's no correlation. So what's happening outside of the body does not necessarily correlate what's happening inside in vivo in the body. So this is an illustration how difficult it is. But I do think we have literature that at the very end of the spectrum, when you're really sick and really deranged from normal, then clearly if you find things in the blood, it's also happening in the cells and in the local tissues.
Thank you very much. I'm happy that the system becomes very simple and simpler every year. So I learn a lot. Thank you so much.
Thank you.